Okay, let's dive into this. Welcome to this explainer, where we're taking a very direct, structured look at the absolute ultimate framework for clinical practice, the comprehensive head-to-toe assessment. Whether we're nursing students actively building our foundation or seasoned clinicians just refining our flow, mastering this physical assessment is absolutely essential. I mean, it's literally how we gather the vital data that drives every single patient care decision we make. Today, we're going to break down the exact sequence, the crucial exceptions you need to know, and those holistic elements that transform a basic physical check into true compassionate patient care. Let's get started.
Everything kicks off with the golden rule, the standard order of techniques that forms the backbone of almost all clinical assessments is inspect, palpate, percuss, auscultate. Think of it like this. We look first for visual clues. Then we feel for texture or any masses. Next, we tap to understand the underlying density. And finally, we listen with our stethoscope. Following this specific sequence is super important because it prevents us from artificially altering the physical findings before we've actually had a chance to properly assess them.
But as with everything in medicine, we immediately run into a critical exception. For the abdomen, that standard rule goes completely out the window. Here, auscultation has to come before palpation and percussion. And you might be wondering, why? Well, because if we press and tap on a patient's abdomen first, we're going to artificially stimulate their bowels. That completely changes the natural sounds we're trying to accurately assess. So remember, for the belly, it's look, listen, and then feel.
Now, before we even think about laying a hand or a stethoscope on a patient, there are some essential preparatory steps. And honestly, these are just as clinical as checking a pulse. Infection control is paramount, so hand hygiene happens before anything else, for sure. Then it's all about introducing ourselves and gaining explicit consent while making absolutely sure the patient's dignity is maintained. Expose only what is strictly necessary. Oh, and here's a fantastic pro tip from the framework. Warm your hands and your stethoscope before making contact. It builds trust, it keeps the patient relaxed, and ultimately, it gives us a far more accurate assessment. And this brilliantly illustrates our complete structured journey. It systematically moves us through the body systems. We start from the general survey all the way at the top, work our way down through the physical mechanics, and ultimately arrive at the psychosocial elements. It is a literal head-to-toe roadmap designed to ensure we don't miss a single vital sign or symptom. We're going to follow this exact pathway right now to see how every piece connects to the next. The assessment actually begins the literal second we walk into the room. Before even touching the patient, we're evaluating their level of consciousness and keeping an eye out for any obvious signs of distress. We observe their posture, their habitus, their basic hygiene. Are there signs of jaundice, cyanosis, or pallor in their skin tone? How clear and vast is their speech? Even our sense of smell plays a huge role here. Detecting ketones, alcohol, melena, or infection right off the bat will immediately steer our clinical focus. Moving right along down to the head and face, a really quick check of facial symmetry gives us an immediate read on cranial nerve 7. We're checking the scalp for any lesions or lumps, assessing basic hearing with a simple whisper test, and inspecting the nose for patency. And don't forget to take a quick look inside the mouth. It tells us so much about their oral mucosa, dentition, and overall hydration levels. While we're still in the face, checking the eyes means looking for PERRLA. It's a classic flashcard definition for nursing students, for a very good reason. Pupils equal, round, reactive to light, and accommodation. It's essentially our baseline neurological eye check, but the framework also reminds us to look a bit wider. We need to check the conjunctiva, inspect the sclera for any discoloration, and definitely watch out for drooping eyelids or ptosis. Continuing our journey down to the neck, we start by verifying that the trachea is perfectly midline. From there, it's just a matter of palpating the key lymph node areas, all the way from the occipital and auricular nodes down to the cervical and supraclavicular regions. 6 specific areas in total. Having the patient perform a simple swallow test lets us feel for proper thyroid movement, and we cap it all off with a quick check of the neck's range of motion. 45 degrees. This specific number is absolutely crucial when we're assessing the cardiovascular system in the neck. To correctly observe and assess the jugular venous pressure, or JVP, the patient needs to be positioned at exactly a 45-degree angle. This angle gives us the optimal view of the venous column, allowing us to accurately gauge right-sided heart function and their overall fluid volume status. Down at the chest, we're checking out the overall shape, like looking for barrel chest or pectus issues, and structural symmetry. We're watching their work of breathing really closely. Are they having to use accessory muscles just to draw a single breath? Once we note the respiratory rate, we apply our golden rule again.
Auscultate those breath sounds anteriorly, posteriorly, and laterally across all fields, listening carefully for normal airflow as well as any adventitious or abnormal sounds. For the cardiovascular exam, we're inspecting for things like peripheral edema or cyanosis before we even think about palpating. We locate the apex beat right at the fifth intercostal space, mid-clavicular line, feeling for any thrills or heaves. Then, we grab the stethoscope and listen to the 4 distinct valve areas: aortic, pulmonary, tricuspid, and mitral. And to complete the whole circulatory picture, we systematically check the 6 bilateral pulse points, from the carotids all the way down to the dorsalis pedis. And as we're assessing those extremities, we absolutely have to check capillary refill time. The magic threshold here is less than or equal to 2 seconds. You just press on the nail bed until it blanches white, release it, and count how long it takes for that pink color to return. If it's 2 seconds or less, peripheral perfusion is looking great. But if it takes longer than that, that is a vital clinical red flag for poor circulation or dehydration. So the crucial point is, as we transition down to the digestive system, we have to flip our standard protocol. Remember that abdomen exception we mentioned earlier? Because we really do not want to artificially stir up the patient's bowel activity, we have to stay disciplined. We have to actively stop ourselves from poking and prodding first and let the stethoscope do the initial investigative work right after we look. So the specific sequence looks exactly like this. First, inspect the shape for any scars, distension, or hernias. Second, and here is the flip, auscultate first, listening for bowel sounds across all 4 quadrants. Only after listening do we move on to light and then deep palpation to feel for tenderness, guarding, or masses. And we finish the whole thing up by percussing for tympany over the bowel and dullness over solid organs. Next up, assessing structural integrity via the musculoskeletal system means we're checking both active and passive range of motion. We're observing their gait, verifying limb equality, and inspecting the spine's alignment. And we're looking for curvatures like scoliosis or kyphosis, because that isn't just about bones. It directly impacts their mobility and even their respiratory function. Now, we don't just guess at muscle strength, we use a standardized 0 to 5 scale. By asking the patient to push and pull against resistance, we can objectively grade them from 0, which means no muscle contraction at all the way up to a 5, which represents normal strength against full resistance. And the absolute golden rule here is to always compare these results bilaterally so we can catch any hidden unilateral weaknesses. Moving right into the neurological system, we formalize our check of the patient's level of consciousness, or LOC. We utilize standard scales like AVPU or the Glasgow Coma Scale when indicated. But on a more conversational day-to-day level, we're checking their orientation times 4. Are they oriented to person, like do they know who they are, place, do they know where they are, time, the current date, and situation, do they actually understand why they are here? To finish up the neuro exam, we dive a bit deeper. We assess the specific cranial nerves as indicated by whatever the patient is presenting with. We test their sensation, their power, and their reflexes. And crucially, we also check their coordination. The framework explicitly points out 2 fantastic tests for this, the finger-to-nose test and the heel-to-shin test. These are super rapid, effective ways to ensure the brain and the body are communicating smoothly. Now, here's an interesting realization. Throughout this entire process, we've actually been conducting a full, sweeping assessment of the body's largest organ, the skin. We're evaluating color, turgor, temperature, and moisture, all while actively hunting for lesions, rashes, bruising, or dangerous pressure injuries. It's also the perfect time to note their hair distribution and check those nails for abnormalities like clubbing while we re-verify that capillary refill. The final physical system we cover is genitourinary. We need to ask them about their last void, their urinary continence, and their frequency. We need to ask specifically if there's any pain on voiding, any hematuria, meaning blood in the urine, or any unusual urgency. And if the patient has a catheter, that requires its own physical check. We ensure it's secured properly, note the color of the urine draining, and verify that the device is actually dated. Now, what's really interesting about this slide is that it forces a total shift in perspective. Up until this point, it can kind of feel like we're mechanics, right? Just checking the pumps, the pipes, and the wiring of the physical body. But truly exceptional clinical practice doesn't just stop at the skin level. The real art of the assessment guides us beyond that physical checklist and steps straight into the human experience. And this is the psychosocial assessment. We absolutely must assess the patient's mood and their affect. How are they actually coping with their current health situation? What do their support systems look like right now? And perhaps most importantly, what are their overarching goals of care?
Understanding these elements provides the real context for every physical symptom we just documented. It literally turns a dry list of data points into a tailored, humanized care plan.
Look at this direct quote. The assessment framework explicitly includes evaluating family and carer involvement along with cultural and spiritual needs. This brilliantly highlights that holistic care involves the patient's entire ecosystem. A treatment plan that ignores a patient's cultural background or disregards their spiritual beliefs or leaves their primary cares completely in the dark is simply an incomplete plan.
And that brings us to our final thought for this explainer. The structured order of inspect, palpate, percuss, and auscultate is incredibly powerful. Knowing to assess the abdomen differently, knowing the exact 45-degree angle for a JVP check, these are the absolute hallmarks of clinical excellence. But after completing this rigorous, systematic process, we have to ask ourselves, we've checked the body from head to toe, but have we truly seen the patient? Because when we combine the precision of the physical assessment with a deep, genuine understanding of their psychosocial needs, that is when true healing actually begins. Keep learning, keep practicing, and we'll see you in the next explainer.